Hello, everyone. We'll give it just getting everyone in. We'll get started. Hello, everyone, and thank you for joining us for today's presentation. I'm Lisa Gutierrez, coordinator at the UT Health Houston Institute for Implementation Science. This event is part of our Institute's seminar series. Before we begin, I have a few quick announcements. The seminar is being recorded and the recording will be available on our website after the event. All microphones are muted, and if you have any questions or comments during the presentation, please enter them in the Q&A box. We'll address them during the discussion period at the end. For those claiming CHES and MCHES credits, please watch for instructions in the chat. Now it's my pleasure to introduce today's moderator, Dr. Bijal Balasubramanian, Regional Dean of the UT Health School of Public Health in Dallas and co-director of the Institute for Implementation Science.
Thank you, Lizette. And you can move this to the, or you can take off this slide. Well, it's truly my pleasure to serve as a moderator of this amazing session. Just really excited to bring all of the leaders of dissemination implementation research across 5 CTSAs in and across Texas. It's pretty unique, and the 5 CTSAs together are in this consortium called the TRCC Consortium, or the Texas Regional CTSA Consortium. The consortium meets every year and rotates across the state and is hosted by each of the CTSAs, at which there is a DNI dissemination implementation research breakout session. And at the last one, when we all got together, the idea for this seminar sort of emerged since the UT Health Houston Institute for Implementation Science hosts the annual fall seminar series. So we thought it'd be great to bring all of the leaders together and engage in a bit of a no fireside, but a bit of a fireside chat around all of the amazing DNI activities that are going on across the state of Texas. So it's truly my pleasure to have all of you here. And by way of just a quick start, I'm going to take just a few minutes to introduce you all, and then we'll jump in. So I'll start with Dr. María Fernández. Dr. Fernández is co-director of the Institute for Implementation Science with me. So it's my pleasure to play this role. Maria is also Vice President of Population Health and Implementation Science at UT Health Houston. She's a global leader in implementation science and has pioneered systematic approaches for adaptation and for planning implementation strategies. Many of you probably know the implementation mapping process that she has pioneered. She's MPI of the CTSA at UT Health Houston, where she also leads the Dissemination and Implementation Core. Next, Dr. Darpan Patel. Darpan is professor and vice dean for research and scholarship at the University of Texas Medical Branch at Galveston, and an expert in clinical research and implementation science. His work emphasizes integrating innovative approaches to enhance health outcomes and advance translational research in diverse populations. Dr. Molly Horstman is an associate professor in the Department of Medicine at Baylor College of Medicine and an investigator at the Center for Innovations in Quality, Effectiveness, and Safety at the DeBakey VA Medical Center. She also serves as associate director of the VA Quality Scholars Program and co-director of the VA Advanced Fellowship in Health Professions Education, Evaluation, Research, with our work focused on advancing hospital medicine, patient safety, and quality improvement for older adults and their caregivers. Dr. George Jackson is a healthcare epidemiologist and implementation scientist who serves as the professor and director of the Advancing Implementation and Improvement Science program at UT Southwestern Medical Center in Dallas. He also holds leadership roles with the Veterans Affairs Health Systems Research Program, directing initiatives to spread evidence-informed practices that improve chronic disease and mental health across large healthcare systems. And finally, Dr. Kathleen Stevens is the Costella Endowed Distinguished Professor who's at the University of Texas Health Science Center at San Antonio, whose research focuses on advancing healthcare transformation through evidence-based quality improvement and patient safety initiatives. Dr. Stevens is a co-investigator of the UT Health San Antonio CTSA, Institute for Integration and Medicine and Science. She's a nationally recognized leader in implementation and translational science. She has directed large-scale interdisciplinary projects, founded the Academic Center for Evidence-Based Practice, and led federally funded programs to strengthen workforce development and healthcare innovation. Thank you all for being here. Phenomenal panel of speakers here. So I'm going to kind of start off with a question that I'd love all of you to take a couple of minutes to answer. The CTSA programs over the years have transformed, and in the most recent iteration, there is a very strong emphasis on dissemination and implementation research that permeates or should permeate through all aspects of the CTSA at every institutions. It would be great to hear from you all what is your university or your CTSA's perspective and vision for how D&I is permeating and integrated across your CTSA. And I thought maybe, Maria, you can kick us off with how UT Health Houston is doing this across its CCTS, as we call it.
Sure. And I'll just start with just a little bit of history. So we have for sort of many cycles included implementation as part of our work in our CTSA. However, before this last cycle, it was included as part of community engagement. And there were some important initiatives that came out of that, including how do we leverage implementation science to improve community engagement, and also importantly, support to work on some of the training that now has developed, and we'll talk a little bit more about later. But I think one of the main differences in this sort of last this last round, the current cycle, is that we were very thoughtful as we were planning the application, and I know that I met with all of the other components to see how can we integrate implementation science and implementation research into the work that you're doing. And so we made sure that not only in the application, but now in practice, we're applying those concepts and principles to practically everything we do. Because, you know, my mantra is, you know, implementation science is translational science. And so even when we're doing things like trying to establish a new clinical research unit in a new area, there are implementation science lessons and tools and processes that we could put into place there. I also think that having the ability to connect with all of the players in terms of how they want to advance their research, and sometimes even in the early translational research, it is framing it in a way that can lead to later greater application and impact. I'll stop there.
Yeah, thank you. No, that's fantastic. George, do you want to pick it up here and say a little bit from UT Southwestern's CTSA perspective of how you all are approaching D&I?
So for background, I came to UT Southwestern about 2.5 years ago to join the newly established Peter O'Donnell Jr. School of Public Health and develop an advancing implementation improvement science program. So that one of the things that UT Southwestern has a long history of close collaborations in research and clinical care with a wide range of health systems, including UT Southwestern, its own health system, but also Parkland. Parkland is a public hospital, VA North Texas Health System, Children's Health, Scottish Rite for Children, a wide range of places where there are opportunities to continue in areas such as informatics, but bring in implementation science across the CTSA and in collaboration with entities such as the Simmons Comprehensive Cancer Center and O'Donnell Brain Institute. The goal being to, from the beginning in the translational pipeline, say, how can things be potentially implemented? So we're have proposals in right now to look at implementation science as part of basic science proposals, all the way through identifying the interventions that have worked really well and say bring those into the health system, but also doing it with close collaboration with the operational side of each of our affiliated health systems. So it's really building long-term bi-directional relationships.
Yeah, there's already, just in two, there's common themes emerging. Kath, longstanding CTSA in San Antonio, can you share from your perspective what has been the vision of integrating D&I through the CTSA there?
Well, our CTSA, called the Institute for Integration of Medicine and Science, instead of a CTSI, but we are housed within the Office of Vice President for Research for the Health Science Center at large. So it's really infused into the very infrastructure for research for the organization. Early on, the CTSA here had planning grant. So in 2008, we began our journey. At that point, as has been mentioned, dissemination and implementation sciences were not necessarily on the roadmap, but what was required was a community engagement core. And those are beginning to merge. They've always been overlapping. And I'm excited to see that moving forward. The interprofessional aspects of the CTSA are very strong, and within our particular response to the latest request for proposals, I think we were the first out in Texas. And so we sort of were feeling our way through in terms of what does the mandated requirement for dissemination implementation across the entire CTSA look like. And we figured out a couple of things that have been advanced and echoed. So we think we're in the right spot. The participation in the Texas Regional CTSA Consortium is one of them. Our 5 CTSAs collaborate there. And it's the foundation for what is housed at San Antonio as the Texas Implementation Science Research Network, or TEX-IS Research Network. So we have a really outward-looking construct within our CTSA.
Thank you. Darpan, let's go down to Galveston and hear your perspective.
Yeah, welcome to the beach. First of all, Maria and Bijal, thank you so much for including us in this panel. And I'm here representing our small D&I team led by Amr Hashmi, and I'm the co-lead for the D&I core here. And thankfully, we've learned a lot in our previous roles, Amr being at UT Health Houston and I being at UT Health San Antonio. And so we brought the collective expertise down to the island here in Galveston. And so UTMB is fortunate enough to be in our 4th cycle for our funding here for the CTSA. And as has been said already, D&I now is a major focus and is now a core within what we're calling the Greater Gulf Coast Translational Science Alliance, which includes not only UTMB, but also our partners at Houston Methodist, University of Houston Clear Lake, and Texas Southern. This is the first cycle in which D&I has been formally listed as a core element of the grant, even though it had smatterings in years past. As our cycle has just begun, we just got funded about 6-7 months ago. We have been intentional in structuring our core to face what we expect to be a big area of interest in our alliance. And so what we're really focusing on is developing a campaign called Demystifying D&I. And the idea is to distill fundamentals of D&I so that way members of our alliance, local and broadly, have a working knowledge of D&I and can identify its utility in their practice and research. And so we're hopeful that by the time our first year is done, everyone will have a foundational knowledge of what dissemination implementation science is, and will be able to leverage the expertise not only within our core, but then the capacity that they've built within themselves, so that our systems in the greater Gulf Coast region can benefit from implementation science and dissemination at large.
Thank you. Thank you. No, that's great. So Molly, give us the Baylor College of Medicine perspective and the newest addition to the TRCC consortium here, and a very unique perspective also across all of the CTSA. So really excited to hear from you.
Thank you. Yes, I'm representing the Consortium for Translational Precision Health, which is the newest Texas CTSA, supporting Baylor College of Medicine and the University of Houston. And I am filling in for Kyler Godwin, who's actually leads the implementation arm of our consortium. So I think as one of the newest CTSAs, we are still in the process of building the infrastructure to integrate implementation across the CTSA. I think, having these two institutions come together, which previously did not have this kind of affiliation, has also been part of this growth for us. But prior to our CTSA funding, Baylor had spent a lot of time and kind of been very thoughtful about trying to build the learning health system, similar to what George mentioned, to really kind of work with frontline clinicians to bring innovation, implementation, to our patient care, and have done that through building groups that within the learning health system. So one example is the Learning Health System Accelerator that we have, where we bring a group of individuals with various expertise to support frontline clinicians. And so I think as we now kind of move into our second year as being a CTSA, of really thinking about how can we use structures that have been successful, like the Learning Health System Accelerator, to really support projects across the translational pipeline, while also really integrating the expertise of our two organizations, Baylor and University of Houston, into a single program.
Well, that's great. Thank you so much. I've already, a couple of very key things that I heard is this bringing implementation early into the translational process, even at the basic science and then clinical research and so on and so forth, not waiting until we have all these efficacy studies, but we haven't really studied its implementation. I think that's fantastic that this infrastructure will allow that. I think the other piece that really sort of struck to me as you all were talking about this is just the partnerships that we've created. And some of you didn't speak to that as much, but Molly and Darpan, you all spoke about it, but I know that UT Health Houston's partnerships go from all the way East Texas and El Paso and others, and UT Southwestern has partnerships across the North Texas area, and so does UT Health San Antonio. So if you start, TRCC probably has a map somewhere, but if you put the map around, the CTSA organizations and partners really cover a large state, and potentially can have a huge impact through the implementation research work that we're doing. So one of the things that has been a recurring theme in implementation science is building capacity to do implementation research and building researcher capacity to do implementation research. And I was wondering if a couple of you can speak to that a little bit more. What kinds of training and maybe research consultations and other opportunities are built into your CTSA that can support new investigators in implementation science, perhaps established investigators who are getting newly into implementation science and really working on that. And so, Maria, do you want to chime in first?
Sure. So this is one of the topics that's close to my heart, because I think that even people who haven't in the past wanted to be implementation scientists, there's many people who are really interested, clinicians, other types of researchers, and so there's a need for training. And so in our CTSA, which is called the Center for Clinical and Translational Sciences, the CCTS, it includes collaborators and partners as part of our CCTS, Rice and MD Anderson and UT Health in East Texas, Tyler, and also Texas Tech. And across this group, there are folks who want additional training. And of course, there's a great need across the US and abroad. And so some of the programs that we have include short courses on D&I methods and tools. And I think Lizette's going to list that in the chat. We have a newly launched 15-credit D&I research certificate program that is open to anyone. There's annual seminar series. This event is part of that. And it also is accompanied by a workshop where we typically have about 20 people who want to have a little bit more mentorship. And then, of course, there's mentorship that's integrated through the CCTS and our T32, K-12, R25 programs. Another really important part of that mentorship and assistance with growing D&I research and practice is our technical assistance and consultation program. So I know that many CTSAs have something like this, where as a core, we provide assistance to folks who are anywhere from just wanting to add implementation into their work in terms of disseminating the results when their studies are done, to really creating an implementation-focused research proposal. And so we have a process by which we solicit, where people can solicit consultations from our core. Another last one I'll mention is a number of tools and resources, and these include online tools for adaptation, for trying to develop logic models for implementation, and one that we're really excited about that's not out yet, but it's a hybrid study tool to help people figure out what type of hybrid they're doing.
No, that's great. That's a lot of great resources. And Kath, I'll let you also chime in on some of the initiatives and resources from the IIMS as well, and others. If there are some things that are percolating as Maria and Kath talk about it, feel free to chime in after that.
Well, thanks, and I really appreciate the Implementation Science Institute for the state, and that's a real step forward. The additional parts that augment in my work have been heavily influenced by the NCATS Dissemination Implementation Working Group, where I first got swept into a wonderful writing group of thought leaders and helped write the first article on translating implementation science across the translational science spectrum. And that's been a real guide for kind of where I wanted to take my work. And from the get-go, our CTSA created a translational science PhD program. We have students enrolled and we track them. Mostly they're in the T1, but T1, 2, 3, and 4 are represented. Within that, I developed an implementation science methods 3-semester credit course, doctoral level offering that could be also inserted in our certification program. But I think it's really interesting to think about what we did in 2020 when all the CTSA hubs came together for a workshop, a 2-day workshop here in San Antonio. And it's published, and I'm hoping that publication will be posted in the chat, but it's published as bootstrapping when you have very little onboard expertise, but you want to get your workforce in implementation science up and running. And all 4 at that time, Molly, Baylor wasn't there, but all 4 CTSA hubs participated in attending and also presenting, and decided to create the Texas Implementation Science Research Network. So training is really important. It's kind of all over the map in a burgeoning field that needs a lot of access to training, but at the same time, it hasn't really been organized around a set of competencies. We're working, we have lots and lots of competencies and activities with that, but there is a compendium out of University of Colorado that lists all the catalogs of D&I training. So it's quite deep and broad. That publication also will be posted in the chat for you.
Thank you. Yes, talking about the chat, we're posting a lot of resources in the chat as we speak, so please engage with that. And if you all have questions about training and other topics that we're going to cover, we really would appreciate if you put it in the Q&A, and we'll try to get to them at the end. So, anybody else? Are there other things around consultations or training that you'd like to highlight? George, did you have something you wanted to kind of jump in and highlight?
One thing I highlight is that we've been working to bridge training and quality improvement and implementation science really they are such close collaborators that we have a long history under the leadership of Gary Reed of excellent quality improvement training, and we're trying to say how can implementation science play there. One example is work that we've done across the Department of Medicine, VA, Parkland, and the School of Public Health as we developed a new community and population health residency program where, along with outstanding clinical training, we're infusing that work with quality improvement implementation in related areas.
Well, that's fantastic. So lots of resources, and these are open to everyone, and especially across the TRCC and across Texas. These are resources folks can engage with. So I really encourage everyone to look into that. When y'all were describing your vision for and activities of the CTSA right off the bat, one of the things I heard about was engaging clinicians, engaging stakeholders. So we have a couple of really interesting sort of case studies, and of course, every CTSA will have something, but we want to take a minute here to have Darpan and Kath speak to a little bit more about the approach to engaging stakeholders, to seeking their input and incorporating into all aspects of the translational research. So Darpan, how is it operationalized within the UTMB?
Yeah, so we have two prime examples of how we're engaging our stakeholders within our alliance around the context of implementation science. And one is really utilizing a research lens around what we're doing and really getting a grassroots understanding of what our stakeholders really need. And so the first thing that we're actually doing is doing a needs assessment of our stakeholders and seeing where they're at currently in their knowledge and understanding and their abilities to do implementation science. And one of the things that we found just in conversation is that there's a lack of understanding of what dissemination looks like, what implementation looks like, and how that looks like in the context of clinical practice versus how it looks like in the context of basic science. And so taking that T1 to T4 aspect of translational science is something that we've identified as a key area of focus. But the self-study is really going to allow us to probe for a deeper contextual understanding of the institutions and where they're at, and really leveraging our effective expertise across the diverse set of institutions and bringing our individuals together and identifying, again, as I said, what our output should look like over the next 5, 6, 7 years that we're in this funding mechanism. The other cool thing, and Maria kind of alluded to this, that you all are doing up in Houston, is utilizing our clinical trials studio as a consultation service within our CTSA or the GG-CTSA. And so the clinical trial studio here at UTMB has been around for years, right? And that's where the scientists come to get a better understanding of how to develop their clinical trials for broader recruitment strategies and get their milestones delivered in a timely manner, right? Check all those boxes on the clinical trial side. But what we're doing is we're implementing no pun intended, a framework within the clinical trial studio to also identify programs of science that might leverage the expertise of our D&I core as well. And so it's not necessarily just a single checkbox. They could always check that box if they want some consultation services on the implementation side. But we're also working closely with the leaders of our clinical trial studio, Kathleen, Vincent, for example, on identifying projects that could lend itself to implementation science, even though the PIs that are putting in that request may not think that it's an implementation science project. And so we're really going to be out there forward thinking in how we engage our stakeholders, being the boots on the ground to understand what their needs are, where their needs are, and then also integrating within the framework that's already been successful here at UTMB to make sure the implementation science lens is being really we're just trying to hit it as hard as we can.
Yeah, and paradigm shifting, so
Yeah.
why wait until the trial is done to understand the how it worked or why it worked or why it didn't work, right? Build it in right off the bat. So I think that is amazing work and so needed. So Molly, I'm sorry, Kath. I'm looking forward to hearing your community approach and engagement approach that you're doing. Sorry about that.
Well, that's all right. So welcome to the CTSA world, and it is a world unto itself. And people who have joined in this conversation today may or may not be deep in the CTSA world, but I'm always sensitive to using a lot of jargon that goes along with CTSAs. From the get-go, community engagement cores were part of hubs, and within that, community advisory boards are very common. And so it's nice to see that some of this commonality runs across, the 60+ CTSAs in the nation. The community engagement colloquium that we have annually here in San Antonio, I think, is unique because it brings together presenters about projects where there is a community-based person using community-based research approaches and in combination with an academic scientist. So we actually get to see these come alive. My particular interest, and you've probably heard me say this before, is clinicians as stakeholders, because we can't get from treatments to patients without having clinicians help carry it across that gap. And so one thing we've done in the Dissemination Implementation Working Group, the national group, is mounted a national survey to see how widely adopted and adapted the practice-based research network models are within CTSAs, because these practice-based research networks are comprised of clinicians. And to Darpan's point, you find out what their biggest need is, what their burning platform is, and that's what you do the research with. Because then, as an implementation scientist, it's a ready-made solution. You don't have to fit it or map it or anything. It's like, here's the answer. So practice-based research networks are a really interesting part to add to our mixture of community engagement.
Yeah, no, thank you so much. And Maria, when you talked about the history, that community engagement was part of the CTSAs, and very fundamental community-based participatory research and principles were baked into it right from the get-go. And that actually, I hear now, is helping with the stakeholder engagement, whether they are clinicians, whether they're communities, patients, and so on and so forth, to really make it participatory across all aspects of the translational spectrum. So some of these examples that we've heard sound really cool. Maybe we have time for one more. Does one of the three of you want to jump in with anything around engagement? Yeah, Maria.
Just a couple of quick things. So our community and stakeholder engagement core that's led by Belinda Reininger are doing some really phenomenal things that are aligned with implementation science, including helping community partners adapt and adopt and implement evidence-based interventions. And so they have a program that they work with communities to help do that. And we're starting to work with them about how do we apply implementation science principles. And another that we're really interested in digging in is the community engaged research dissemination model. That's a model that sort of looks at how do you disseminate findings to communities and how to ensure that communities are actually engaged in that process for how you do it. And I think that implementation science sort of frameworks and processes can really help to broaden that existing model.
Yeah, no, thank you. So important to get evidence-based messaging out there to the communities in the current time. I'm going to make a little bit of a shift here to talking about, you mentioned jargon, talking about this other thing called the learning health system. And of course, many of you will have heard about that in the audience as well. But improvement and implementation science is one of the foundational pillars of developing a learning health system. And there's also now a lot that's being talked about and written about a learning public health system. So not just the health system, but also involving the communities. And many of our CTSAs in Texas are working in this space. And I want to call on Molly and George to say a little bit about how the CTSA's infrastructure, the health system, and the resources that are in your hub kind of interact towards the development of, or perhaps it's in a great place and the running of a learning health system. So Molly, do you want to kind of kick us off on this idea of a learning health system and say a little more?
Sure. I think the connection between the CTSAs and then the healthcare systems that are affiliated with our CTSAs is really critical is in this building of learning health systems and being able to bring our research findings to the bedside. And, I just want to acknowledge that depending on where you're at, can be a real challenge. As I said, we are a combination of Baylor College of Medicine and the University of Houston. We have a lot of clinical partners that are not operationally linked or affiliated. And so it's takes quite a bit of work, right, to be able to have those two, the research side and kind of the operational clinical side to be able to come together. And, I think all of the institutions, all the CTSAs in Texas, we have lots of really smart and capable and passionate people that work at our institutions, whether it's from the research side or the clinical side, that do really want to see research get into clinical practice and improve the lives of the people that we take care of here in Texas. And I think a lot of that comes in figuring out what resources people need. And I think, as I mentioned, that's a lot of what the early work we've been doing here through our CTSA, because there are resources that the CTSA brings. So things around technical expertise of implementation science methods, improvement methods. But we also need the healthcare system because they have the data. They have the informatics, access to the electronic health record, project management expertise for how to get things done within that institution. And it really being able to kind of bring the two of those things together, which is in part what we've been working on as part of our accelerator. And, I think, we get proposed, we have a lot of great ideas that get proposed to us, right? A lot of things have merit. And I think we all realize that particularly when we're working with healthcare systems, the resources are finite. And I think that's kind of the next thing that we've really been kind of thinking about and working on is really how do we make sure that these research ideas that are coming that are really great match the needs. This gets back into some of the kind of key partner and stakeholder, but meet the needs of that healthcare system so that it can, really have the best chance of success. So choosing the right time and place for that research that has merit to come into the clinical side. And, I think that's something that we're continuing to refine as we do this work through our learning health system.
Thank you, Molly. George, do you want to jump in here and say a little bit?
I think the really great thing about the learning health system, I sort of mentioned this earlier, is the bi-directional relationship. It's not just doing research within the health system, and it's not just consulting with the health system. It really is both. We have a long history of that close clinical and research connections. One area we've been doing a lot of work is the connection between our Center for Clinical Informatics under and the implementation science program, so we can really understand how we can use that data to be able to inform both opportunities for implementation and did we implement things effectively. And so, for instance, we're currently doing a joint recruitment with their center and our implementation science program to really cement that relationship. The other is that we've got people working in implementation across all of our health systems, whether that's palliative care, genomics, cancer care, disease prevention, telehealth, and they're working across all of those systems, developing the relationships. And I think that's the big thing, to both implement things and study it, but also be able to be real partners in improving care. So I think that's really been our focus at UT Southwestern across all of our health systems, real health systems with which we work.
Yeah, and right, and I appreciate what you're saying because you're sort of connecting the dots between the data infrastructure with the improvement and implementation infrastructure, and doing it while getting the entire organization sort of on the same page and having everyone equally engaged in systems where we're not necessarily incentivized to collaborate. So there is a huge culture change that's needed in doing these learning health systems. And having said that, is there like a bright spot? Like, is there an example of some aspect of a learning health system, and any of you can take this question, that you think is working, that gives us hope that this very big endeavor can actually be accomplished? Does someone want to? Maria, I see.
I don't know if this is so much of a bright spot, but I did want to mention it because I think that it's, when we think about learning health systems, we typically think about clinical practice, hospitals or community health centers. And I think that there's an opportunity. And in fact, Bijal, you're very familiar with this since you lead a lot of these efforts, is the capitalizing on other partners that are interested and need implementation expertise, like schools, like volunteer organizations, patient advocacy organizations. And I think, one of the ones that I work on a lot is the Multiple Sclerosis Implementation Network. And this was a network that was put together by the Multiple Sclerosis Association of America with the purpose of connecting providers across the country to do rapid cycle implementation research. And like George was saying, critical to this endeavor is making sure that it's bi-directional and that there can be a co-creation of a research and practice agenda. But so I think that that's that both a bright spot and also a new area that we want to think about is non-traditional partners in terms of learning health systems and practice-based research networks.
Yeah, no, absolutely. Love the work that we're doing in MSIN. Oh, go ahead, Kath.
Yes, just one little quick example, because I find concrete always helps me. We are just bathing in data and clinical data, and the potential of using AI to now manage that and squeeze out how we can predict what the next view of a care case like this might look like with higher quality. We replicated a CTSA on the East Coast where they went in and they identified 54 variables within the EHR that connected to this thing that we called a frailty index, which of course a frailty index will predict utilization of healthcare and the subsequent eventual course for the elderly. And to me, that was like using the data at hand and using those data to come up with an index that we otherwise didn't have. And it's being replicated, I think, George, in some of the work that Mike was doing in harvesting EHR for anticipating some diabetes issues. And to me, the concreteness of what does a learning health system look like, these are small examples of how we can use it.
Yeah, absolutely. Absolutely. So I'm keeping an eye on the clock here as well. We have about 15 minutes, and I didn't want us to leave without asking all of you a really important forward-looking, Darpan, using your word, a question. The field is rapidly advancing. It's very dynamic. I mean, relatively still newer than other more established disciplines. So either from the perspective of advancing the science of implementation science, so the field, or the CTSA itself, what are you seeing as the next big steps? What's on the horizon that you are excited about and that's really, really important for advancing D&I research? And I thought maybe I'll start with you, Darpan, on that.
Yeah, sure. I know we're wrapping up, but thanks again to you, Bijal and Maria, for this invitation. And I mentioned Amr earlier, but I also want to give a shout out to some people behind the scenes, Stephen Muldrum and Vicky McNamara, who really helped drive the ship here at UTMB's D&I core. There's a couple of things that our next big thing here is going to be at UTMB and answering the question of what's on the horizon. One, I think, is just the science of implementation. We feel that oftentimes we get so clouded or focused in on the implementation science part of it, where we forget about just looking at implementation as a construct, right? We get so caught up in the scientific methodology, and yes, that's important, right? But at the end of it all, it's ultimately what we need to figure out is how is it going to impact the patients that we serve and the clinics that we are working in. And so if we could kind of get out of our own way to a certain extent, and really understand best practices in the context that we're working in, I think that's going to make a big leap forward in bridging this gap between implementation science and true implementation. The other, I think, and picking up on what you said, Bijal, is that implementation science is still relatively young in context to other sciences, other areas of research. And so developing a culture is going to be very, very huge. And as many of us alluded to, for the first time, implementation science, dissemination implementation science is a major focus of CTSAs now. And those of you that are in the audience are maybe even putting together proposals to include D&I as a major core. And so context is key, right? And really understanding where our stakeholders are and understanding what their barriers and facilitators are to implementation success is going to be very, very important to establishing a culture of research in this environment. And so as we think about what the next iteration or next few years look like for us locally and maybe even nationally, it's to really develop a culture in which implementation science or implementation frameworks are part of the normal conversation and not thought about after the data has already been collected or the study's been done. Because at that point, it's already been too late.
Oh, wise words. I completely agree with you. George, did you want to chime in? What's next on the horizon from your point of view?
Really, going off of what Darpan was saying, it is implementation science across the entire translational continuum. So as I mentioned, we're excited about how do you think about translation from the very beginning of basic science and laboratory research through the clinical trial process while you're doing the drug trial. I get to be involved in some of those types of work myself, through what I think has been sort of what I call traditional implementation science, which is, as I was saying, it's still important. You get really good trial data and you move things into the health system. But so it's how do we do that, and but also how do we demonstrate our value as both a field and as the learning health system concept, and those two closely connected as entities in and of themselves. It's really important to do this in individual studies, individual projects, but also to study what's the impact that we have as implementation scientists and practitioners on the healthcare system as a whole.
Absolutely. Molly, I know I'm going kind of haphazard and you'll be like, listen, did you want to chime in, Maria, or just wait a second?
Molly can go. Molly can go.
Okay.
I I don't know that I have much to add. I do think, this kind of interest in implementation science and people who I think previously may have not seen implementation science as part of the work that they needed to do, and coming to that has been really exciting. And the investigators, who may have seen themselves as more basic or clinically oriented researchers now realizing that, I think is just really great. And I think this, George kind of brought up, and other people have talked about this bidirectionality between the CTSAs and whether it's the healthcare system or, as Maria said, the community is really important. I think you asked for concrete examples, and one of the things that we've been working on at Baylor is really integrating genomic data for our patients into our clinics, right, into our primary care clinics routinely, right, having it be a normal part of care within our Baylor Medicine clinics. And that really does require this, bi-directional part where the, basic scientists, clinical researchers, and the healthcare system, all have a stake in this. And so I think that part is really exciting about how do we do that, while also kind of, as I think Darpan said, demystifying some of it, making it seem like something that we can do and should be doing routinely, and that it's not something that a select group of people do, I think is really exciting as we look forward.
Thank you, Molly. Kat, why don't we go with you, and what's on the horizon with implementation science and CTSAs from your point?
Well, it is really what the foundation is. All the way from the beginning, we do research for a reason, and it's been pointed out, we get so driven into the technical aspects of research, rightfully so. But I'm always reminded, about a year and a half ago, the former president of the Health Science Center, Bill Henrich, who passed away about 6 months after he said this, said something that has become a guiding light for me as an implementation scientist. And he said, as researchers, we must first ask, does anyone care about the answer? And to me, that really is, then we find out who those people are who might care about that answer. And we engage them in, all the way across the spectrum, informing us along the way to know if we finish with 1T1 to T2, then who do we hand it off to next? And it's all about creating investigative teams that are so heterogeneous that it's a blessing because, better, faster, quicker, more research come out of investigative teaming. But at the same time, it adds even more complexity to implementation science, which is really about operational caregiving. And so calling forth, the interest in team science, what does it look like to collaborate? How do you collaborate across scientists, clinicians, citizen scientists, the community, in such a way where there's authentic partnership and a real vested interest, not just help me recruit to this RCT by knocking on people's doors, although that's important too. But I close with this, and it is from Mark McGovern. You may have remembered his presentation to the Dissemination Implementation Working Group, which, by the way, is a learning collaborative. That's a way to learn about this. Just jump in and immerse yourself. They did a project building the DIRC-SS. It's the Dissemination and Implementation Research Capability Self-Survey. And it's based on teams, investigative teams, to ask yourself, those of us in the health and social sciences research fields, can we evaluate our project's potential for successful adoption and real world use? And after doing this project for a while, they concluded, and this is a bit tongue in cheek, but I'll leave you with this. The project exposed the fields of implementation dissemination as an ironic nightmare of theories, models, and frameworks with a beleaguering and infinite warehouse of options for non-experts. And I paraphrase that, and I see Maria smiling because that's exactly why you've established this wonderful Institute for Implementation Science.
Perfect segue, Maria. What's next and how you want to respond to this? And I have also been having to grapple with this very difficult issue with a somewhat newer discipline. But go ahead, Maria.
Yeah, I think that it's something that everybody's paying attention to now, right? It's like how we've gone a little far afield in trying to establish ourselves as a legitimate science, and trying to do so, I think maybe have gotten a little bit away from the pragmatic nature and the real purpose of doing this science in the first place, right? Is that so that it can be used and improve practice and improve the use of evidence-based interventions. But I think that a lot of the things that we've been talking about so far, including developing these learning health systems and practice-based research networks and community engagement, is really going to go really far to help address that issue. In terms of moving forward, I'm going to tell you a one science thing and one application thing. So mechanisms of implementation strategies, I think, are really important to study more. We need to move beyond, does this work, and understand how and why it works. And this is really critical, both for adapting implementation strategies to different contexts, as well as trying to boil it down to really what works instead of doing a lot of extra things that aren't necessary. And then, and this is related, but I think this idea of precision implementation, where we're tailoring strategies to specific contexts, populations, and settings, I think that this is really important. And I think there's a lot of potential for developing decision support tools to help that happen and help incorporate community engaged activities to make sure that the strategies that we're using make sense. And finally, one of the things I'm really excited about here, and this is largely due to the collaboration with our McWilliams School of Biomedical Informatics is the integration of digital health and AI with implementation science. And I think that we can help each other. For example, we can use large language models and AI for real-time monitoring of implementation fidelity. So, these fields can help implementation science, and then obviously implementation science is needed to help improve the adoption and use and sustainment of some of the really cool things that are coming out using AI and in the practice of medicine and public health. So I'll stop there.
Yeah, that's fantastic. I agree with all of you 100%. I mean, yes, implementation science has created all these theories, models, frameworks, but at the same time, it has raised the awareness of how much we didn't know when we were in just the RCT paradigm, and how much we do need to know how things work and why they work and why they do not work. And so I think that that's really important. And I agree that we need a bit of a course correction where the pragmatic and engaged way of doing research is fundamental and is not short-circuited in the science of doing implementation science. So I think this is phenomenal. I just want to kind of wrap up a little bit with a couple of the few things that I want to just highlight. The next TRCC consortium meeting is in Galveston in June. We will have a great breakout session at that point as well. It's a statewide gathering. So folks who are in implementation science or involved in the CTSAs and would like to go, I just wanted to send that out as a very early notice. The other is that several of us in the TRCC work group and across many CTSAs are having a networking dinner next week at the annual Dissemination Implementation Research meeting. So I'm looking forward to actually seeing you all in person. So I wanted to sort of share that. And with that, I want to thank you all for taking the time. I think this was a phenomenal conversation. I hope that the audience really got to hear about all of the amazing things going on across just unprecedented 5 CTSAs, large CTSAs with network partners across the state. We didn't get a chance to talk more about how we are all collaborating, but there's a lot of really amazing things where there are cross CTSA collaborations that are also occurring. So I think it was an opportunity to feature that. So I want to thank you all. There were a couple of questions in the chat, but I don't think we're going to be able to get to that. But we will respond. I will respond offline to some of those questions. Thank you again, everybody.
Thank you.
Thank
Thanks,
you.
Bijal.
Thank you.